Okay. Um, so welcome, and let me just check in and see how you all are doing. I know this is it's a normally busy and exciting and sometimes nerve-wracking month for fourth-year students, but then we've got some added tensions just as things are happening COVID-wise, but also just politically in our country. So how are you managing? How are you doing?
I'll go first because we're just staring at each other, but
I noticed that.
I'm really tired. It feels like all of us are really, really tired today.
Yeah.
The weather isn't necessarily making it easier either to wake up.
Yeah.
But I'm tired. Good, but just ready to be done with interviews and to be done with matching and figure out life ahead. It's
Yeah.
nerve-wracking to be sitting in this kind of limbo space.
Yeah.
But I'm exhausted. Like, coming up with sentences has been difficult. I'm so tired, as you can tell. But yeah, I'm good. I'm just exhausted. I feel like I could sleep for 2 days and then be finally caught up.
Yeah.
I slept for like 9 hours last night and I'm dead
Yeah.
tired today. So
Yeah. Yeah. Does that feel kind of true for everyone? Yeah. And so that is accurate. I think more so now, and we're still on Zoom, and you know we still don't know answers. So part of what I want you to hear is that taking care of yourself is critical. And I know that's hard to do in your space. And part of what will happen for fourth years is that we'll get through this month and you'll get your interviews done, you'll get your rankings done, and then you'll recognize that classes have started without you, and you'll feel behind. And so it's going to carry on for a while. And so taking care of yourself, getting time away from screens, getting time away from maybe the news, and finding ways to just connect with people or connect with nature, whatever it does for you. Lauren, don't take hikes right now because that won't be helpful. Um, and we'll just work together as we go through this, because we can do this. I just had to verify you again today. So I checked everybody and you're still on the way to matching and it's still in the process. They're emphasizing this more than before. So, you know, they said this time, make sure that nobody's on your list who isn't in your, at your institution. And so it was a little bit weird. So I don't know what's happening out there, but they must be having some mix-ups somehow. But everybody in our group is fine and you're where you need to be. So anything else before I launch into the class? I can feel it, Louisa. Yeah.
Oh, no, I was gonna ask if there are more students in the class and that some of them are interviewing.
Yes.
Okay.
That is true. So I am recording today because I've had several people tell me that they were missing today. Some of them are missing today and next week, and that's just the normal thing. So I'm gonna go ahead if you notice that somebody else, one of the things that happens is that people start coming in at 8:40. So if I'm going along and you notice that somebody's trying to get in or they text you, let me know. So I will tell you a little bit about why I'm teaching Psychopharm. I have my disclosures on a PowerPoint I'll give you. I didn't start out thinking, oh, I want to be a prescribing psychologist. And I have never wanted to be a psychiatrist. I've worked with a number of psychiatrists. I'm glad I'm trained as a psychologist, and I have loved my role as a clinical psychologist, as a neuropsychologist, because I have never wanted to be a med manager. And one of the things that I saw, particularly as insurances and Medicare and Medicaid started really doing some changes throughout the 1990s, psychiatrists just really changed. When I was at the University of Colorado, I worked next door. I mean, our offices were next to each other. I was working for a neuropsychologist, but the psychiatrist was next door. And he was one of the few psychiatrists I have worked with over the years who was also a therapist. And he was a skilled therapist. It was interesting. He was kind of a psychodynamic psychiatrist. And so he did prescribe medications for his patients, but also for patients in of other providers in our group. There were other clinical psychologists and then the one neuropsychologist. He would have me occasionally do neuropsych for his patients. And so we got to have some good conversations. Most of our conversations were not about meds. They were about therapy and working with people with trauma. I have a funny story about him, but I'm going to not tell that right now. But then when I was working in the community mental health center in Idaho, our psychiatrists, we went through several of them as the laws were changing. And I remember a period of time that was just awful. Our psychiatrist would come in one day every other week, would have 7-minute appointments with our patients. Technically, we billed for 15, but he would only see people for 7 minutes, and it would be, so how are you feeling? How are your meds? Are you taking them? Okay. And then either he would say, I'll see you next month, or it would be, let's go up or down. It was horrid. It was horrid. And I have never wanted to do that. But I recognized, particularly as I worked with a lot of people with head injuries and more severe mental illness, that I was always running into questions about meds. And so I watched the prescribers I watched for a while what was happening with the 10 who went to the Department of Defense and went to basically medical school for Psychopharm. They were actually at Bethesda in medical courses. And then I watched as they began prescribing. And then as the programs for Psychopharm began to develop, I also watched those. And a couple of the new ones at that time, Farley Dickinson was one, and then California School of Professional Psychology, San Francisco was the second one that came out, and I watched that one for a while. And finally, I decided I was going to do it. There were a couple of reasons. One, I wanted to know. the information. Two, I thought as a neuropsychologist, if I were a prescriber, I could really benefit my patients because I could prescribe for them because I spent more time with them than their psychiatrist did. And I knew more about them than their psychiatrist or their PCP. And so I thought, well, this might be a helpful thing. And I was in a state that it would take you 6 months or more to get an appointment with a psychiatrist. So most of the psych meds were prescribed by nurse practitioners or by internal medicine or family medicine. And also we have to get continuing ed. And I thought, well, I pay for continuing ed. I get a few credits. I need 20 per year. Why don't I just get, when I'm done, I have another degree. Now, with continuing ed, you might have to take a test. In some of them we do. And if you don't pass it, you don't get the credits. Most of them we don't. But going into this program, once again, I was taking real tests on real dense content. And so I applied, was accepted, and went into the program. When I started, it was 2 years long. When I finished, they had made it 3, but I was able to finish it in 2.5 years. And then you had to have a year of, well, not quite a year. You had to have 200 hours across a span of several months of working with a prescriber. And that was called our preceptorship. And then you took the PEP exam, which is another national exam that you have to take to be a prescriber. Well, I was in a state that didn't even want to hear about psychologists prescribing. I was involved in Oregon's process toward trying to get prescribing privileges. Oregon has been through the process 3 times. The first 2 times didn't even get close, but I was part of that because I only lived 45 minutes from Oregon, and I had people who would come to see me from Oregon. So I thought, well, I'll just get my Oregon license. And I had a physician and nurse practitioner that I consulted with a lot, and they were willing to have me be part of their practice just to do this. And so I was part of that. And then the opportunity was to come to Oregon. And I was trying to do things, we brought in speakers. I can remember we gave people free steak dinners one time with Idaho Psych Association to think about prescribing, and it was no way, no way, no way. I was the only one in Idaho for a long time who had the degree, and then there were a couple of others who were working on it. And so I then moved to Oregon, and in 4 years, Idaho got prescribing privileges, and the Oregon governor vetoed the bill when it got to her desk. So I have not taken the exam. I have friends who have, because you can't, there's a time limit. So you had to take the exam, and it had to be, so you had to get prescribing privileges in so much time. I considered going to Indian Health Services because I could have prescribed there. But when you're part of Indian Health Services, they get to deploy you. And I wasn't sure how I felt about that, nor how George Fox would feel if all of a sudden Indian Health Services took me and put me somewhere else for a few months. So I didn't follow through with that. So it was a journey. It was a thoughtful journey. I'm glad I did it. It has been so helpful. In Idaho, I frequently consulted with medical people who were prescribing who didn't feel like they had the knowledge to prescribe psychotropics. And so that was meaningful. I got to have say in what my patients were taking, and it's helped me work with patients on understanding what might be beneficial for them. So anyway, that's how I got here. I'll give you a little bit of the disclaimers that I need to give you as we go a little bit farther. Any questions at this point? Okay. All right, let me talk about the class. This is a dense class. The way that we think about psychotropic medications has changed. When I first started, when I took this, there would be a class in mood stabilizers, and we would spend, a month in mood stabilizers. Then there'd be a class in anxiolytics, and we'd spend whatever time in that. And the last few years, because medications are changing and how we use them is becoming, well, it is changing in a way, although we have used them what we call off-label for a long time. But now what might have been off-label might now be an FDA-approved way. They cross these lines. So, for instance, one medication that we'll talk about a lot is Abilify, and you probably have heard of it. Abilify was first approved to be an antipsychotic medication. It still is, but they found that its chemical consistency was helpful to be a booster or an adjunctive medication for other meds. So a lot of times you'll see people who have depression who are on low dose Abilify, and what that's for is to help maybe their SSRI, maybe their Lexapro work better. And so they're on these two meds, and people will say, well, why are you on Abilify? I looked that up and it's an antipsychotic. It's because Abilify is one of the best boosters that we have. Another one is lithium. And so lithium is still the #1 medication for use with bipolar 1, although we'll talk about the real difficulties with lithium later on. But part of the difficulty, lithium in, again, lower doses is really beneficial as a booster for medications. And so sometimes people will be put on lithium, not because they have bipolar, but because it's being used to boost something else. We will get a little bit into some of the medications that interfere or interact with psychotropics, because when we are working with people who are medically complex and have medications for their physical diagnoses, their medical diagnoses, they will interact with the psychotropic meds. So for instance, when a person has Parkinson's, the first thing that they're usually put on is an antidepressant, because when you have low dopamine, you are going to have depression. So before the tremors get to the point where they're interfering, a person can be put on an antidepressant. But the #1 medication for Parkinson's early on is levodopa, which is a precursor to dopamine. And so you don't want people on a dopaminergic medicine and then give them a dopamine precursor, because that causes problems. We have medications that we give to people that we feel comfortable with that interfere or interact with birth control. So there are some real serious things that we have to look at with women who are on birth control during childbearing years. And so we'll look at some of those. The first thing that we're going to do is we're going to go over paradigms. We're going to go over some of the basics. I used to have people coming into this class take a biochem, neuroanatomy, cell anatomy exam, and they had to pass it by 75%. And in my brain, I was thinking, well, they've had this background. And so I needed to know where we were, because we have to know biochemistry. And that didn't work. Number one, it was anxiety provoking for the students. I let them take it 3 times. 3 times wasn't enough. And it was lasting so long into the semester that it was interfering with class. So this year, you're going to have an activity. And I just want you to go through the activity, and it will be on Foxtail. I should be able to get it up today or by Monday. And I will have it open for several days. Get in, and you need to pass it by 75%. And I don't care if you work together. You each have to obviously do your own, but help each other, because what I need for you to do is become familiar. And these are some of this you would have been introduced to in biobasis, but some of it maybe not. And so I want you to know some of the things that are just background, so that when I talk about them later and you'll know the language, then we will be able to do that. So it will feel like an exam a little bit, except just remember, this is an activity. I just need you to get into this material, and I don't want to I'll do a little bit of it as we ease into pharmacology, but I don't want to do the details that far back. We don't get enough time. So those of you who have just joined us, just know that this class starts at 8:20. I know it's a weird time, and this happens all the time. And just to let you know, we'll be in March, and you'll come in at 8:40 and think, and that's okay. You know, we'll just manage it. I don't balk at the 8:20 because they only give us till 10:10, and I talk fast. Okay, you have exams. So let me tell you why you have exams. You are tired. This is your last semester. You will have senioritis like you've never had it before. You're not done with this whole process of getting into internship. I know that on February 19th, in fact, February 5th to February 19th, you're going to try to get your brain to work, but it's not going to cooperate with you because it's still wondering what that silly computer is doing. And then the closer we get to the 19th, the less your brain will work for you. I know that. I've done this a number of times. And then on the 19th, even if the news is the most glorious news you could ever have, now other forces are going to distract you because you're going to have your new training director start the onboarding process. And those of you who go to VAs, there's a boatload of paperwork. Those of you who are going to militaries, there's a whole boatload of paperwork and things you have to do. Some of the rest are a little bit calmer, but now you have to figure out if you're moving, where you're going, and how you're going to get there. And now you have to talk to your practicum supervisor about when you really are going to end practicum, and you have to start talking with all your patients. It is just busy. And then you come Friday morning to this, what I hope is really interesting. So I have exams so that you put some of this in your brain, but this is how we do it. The book that I use is Dr. Preston and Dr. O'Neill were two of my professors when I took the course. I've used this book. When I started teaching psychopharm to master's level people, there was no way. They didn't even have the background that you have. And so I had to teach them how to use the tools. By the way, they would, in these programs, I would start Friday night, teach until 10 on Friday, teach all day Saturday, teach all day Sunday. And one of my evaluations was death by lecture. So I try not to do that, but there's a lot of stuff. So I will bring in cases at times, and just to make you think. And the cases will be ones where my goal is to help us think outside of the boxes we've been used to. And so I hope to help you think about, how do you approach your patients? Why are some of these questions important? How do you figure out information? So then you will work with each other, and the best thing to do is for most people, not all, is to have study groups and work on this. But my goal is that you can think in different ways and you know how to use the tools. So when you come to the exam, they are timed exams, but I give you, I've received some feedback, and so I give you, I think it's not quite 24 hours, but you will take it on your own outside of class, and you can use all of your notes. You can use your textbook. You can use the web resources that I'm going to introduce you to. What you can't do is call a friend or call a prescriber. So what I'm hoping that the exams do is provide you situations where you practice finding the information in your tools. Now, there are too many questions and too little time for you to come to the exam without studying or without organizing. And so studying helps it get in your brain. And then when you come to the exam, you will know many of the answers. And by the way, there are at least 2 scenarios. And in those scenarios, there's not just one right answer. What I'm looking for, I saw that, Louisa. What I'm looking for is that I need to know how you're thinking. And so you might do a diagnosis. You might suggest a medication that will be helpful. And I've had students say, well, I'm not, this is out of my scope of practice, and they don't name. In this class, I need you to name, because I want to know how you're thinking. And not that you're going to go and start naming to prescribers at this point, but I want, in this class, your scope of practice is what I ask you to do. So when people have said, this is outside my scope of practice, I give them feedback that in your practicum, maybe, but on this test, no. And so when I say, what medications do you think would be most helpful for this person in this situation, I want names, and I want you to tell me why. Okay? So there, I think we have 3 exams. Why don't I know? Because I forgot to look at it, but it's in the syllabus, and it's on.
I think that's what we talked about, Dr. Andrews, is
okay.
That registers with me too.
Okay. I try to compartmentalize them to what we're doing, but with medications, they always leak into other places. So what we'll do at the very beginning, you will see all the way through the exams, because what we do at the very beginning is our foundation. I have you do a case. Well, the first assignment is that I have you pick a medication and I have you do a deeper dive into that medication. I would like it to be an FDA-approved medication because those will have more research on them. So if you have the textbook, in the back of the textbook is a real good quick guide with all kinds of names, some of them in are words that you can hardly pronounce. But it might be a medication that you see coming up in your practicum over and over and over again. And I have the assignment in the syllabus. It's on Foxtail, and it gives you details. This is not a long paper, but it probably is 4 or 5. And then the other one is that you're going to find a patient I'm hoping in your practicum. That's easiest to do. And that person needs to be on at least 3 medications, and at least one of them is a psychotropic medication. And I'm going to have you do an analysis of the case. That comes a little bit later, so we have time. By the time you do that, you're kind of out of the interview match brain fog a little bit, and people can think a little bit better. So, but you want to be, as patients are coming across your schedule, you want to be aware of patients who are taking multiple meds, and at least one of them is a psychotropic med. So some of your patients are taking psychotropics because they have chronic pain, not because they necessarily have a mental health diagnosis, and that's okay. I want us to look at the interaction and why people might be taking certain meds for different reasons. Okay, the other thing is, Kristen is in our class taking it as a student, but she's our TA. And this is why. Kristen took psychopharmacology before she came to our program in the way that I taught it when I was teaching 2 semesters of psychopharm. And so I've had her be my TA because she knows this at a deeper level. She's a good resource. But you've not sat in on lectures, have you, Kristen?
I mean, last year I taught 2 of your classes, but then no, normally in second year I had my own classes, and then last year, I don't know what I did on Fridays last year, but I came maybe just a couple times to teach, to help out, but I've never sat in on classes.
Okay. So, so one year, I don't know if you know David Neal, but David Neal was a nurse for about 10 years before he came to the program, and continued to do nursing work through the program. And so he was my TA one year and sat in on the class very much like this. And it was really helpful because there are times when he could explain things in a way that would go beyond, because I've never worked as a nurse, and it was helpful. Kristen will be able to run study groups for you, and she will know background. She also has graded some of these papers. She will be grading your papers. She's not writing her own. That's my agreement with her. She's going to come to class. She will help as my TA, and then she will be a resource. So when Kristen, when she interfaces with us, it will be because she has been working with this stuff for a while, and I've invited her to participate that way, because when David Neal did this, I found it to be very helpful for me and very helpful for students. Now, I have been on the governor's task force for mental health, what's it called? Task Force for Clinical Mental Health, something like that. We call it MCAGS. And so I've been on it for going on 3 years now. And our task has been to develop algorithms for prescribing medications for prescribers in the state of Oregon, particularly those who are not psychiatrists, but who live in more rural areas and might be seeing patients with mental health issues, and there's nobody else to prescribe. So we've been developing, we started with schizophrenia, we have finished, it takes forever. It's a task force of about 15 across, most people are psychiatrists, but they're across different kinds of environments. So we have several, for instance, we have from Oregon State Hospital, we have the lead pharmacist and the chief of medicine for Care Oregon. We have the NAMI, the head of Oregon NAMI. We have a couple of psychiatrists from OHSU who work on a specific referral. And so these are people who are working with people who are low SES, who are on Oregon Health Plan, people who, oh, and then I'm there. So why am I there? Because they needed a clinical psychologist. And there have been a couple of times, it's an intimidating group, believe me. There are a couple of times when I've had to speak up and talk about what it's like from my side. And they listen to me now. It took a while because most of them do not know that I have this degree in psychopharm because OHA won't put it on my name badge. I've talked with them a couple of times. And so I have PhD, and they don't know that I have the MSCP. And so when I talk about medicines, they always kind of look at me weird, but we've been together for so long now that when I speak, they do listen a little bit more. So I'll show you some of that information. It's I have the schizophrenia one on. It is public domain now. Schizophrenia, and I think bipolar has been published. I wasn't able to find it on the OHA website, so I will figure out how to get that access. And so you'll see some of the different ways that we're looking at medication and what Oregon prescribers are seeing when they are being helped in how do you prescribe for this. And we're having to teach about, you know, when somebody's, that not all mood swings are bipolar, that not all sadness is clinical depression. And so we're looking at some of those things as well. Okay. I think I've gone through the major things of the class. Are there any pragmatic questions that you have?
All fourth years have passed your class, right?
Yes, nobody has died. Death by lecture is not true. Some days I think people want to put their head down and take a nap. And I just keep plowing through. There's tons of content, and I try to make it palatable, and I do. This format is hard because usually we have a million questions, and so by next week I'll do hybrid. So those of you who, and I don't know what your A/B schedules are from whoever gave them to you. And frankly, I'm just gonna leave that up to you. And if you need to stay Zoom, want to stay Zoom the whole time, I'm fine with that. You don't need to get my permission because COVID's doing weird things. And, you know, some of you just need to be home and be safe. And I want to respect that. We have PA students in our building now, and they haven't quite learned that it's not their building, and that they need to share with us. And by the way, we've been here longer. Not that I have an attitude toward them or anything, but no, I've just heard hall comments that they think they're the only ones going to class. They didn't have a Zoom option as they started, and they just started this week with classes. They had orientation last week. So they haven't met us yet. PT is back. So but they go into different halls, so they don't, the only place that they'll interact with each other is probably in the front entryway. So it'll be interesting when we start coming back. So I'll start next week doing hybrid, but you make choices on what's good for you. And again, I understand that we've got at least one more Friday where we have a number of interviews. I think for our cohort, I think the 27th might be our last interview day. I don't know that anybody's going to the 29th, but so by the 29th, we might all straggle in and all be here, and we'll work together. Okay, so nobody has died. Nobody has failed this class since, well, I don't remember that anybody's ever failed this class. People have, this is an elective class, and some people have wanted to be in the class but needed to make choices that I approve of. And so I've had several people get B's. I've had one person get a C+. And that is because that person needed to make that choice but wanted to be here, did the best that they could given the other choices that they needed to make. So we're gonna make it. Okay, I'm horrible at breaks in this class. So if you need a break, you know, you have that, I think you have that reaction emoji that's a coffee cup. And so we can do that. Why don't we take a 5-minute break now? Actually, a little bit longer. Why don't we come back at 9:10, and I will plow into our first lecture for today, okay? So I'll see you at 9:10. Okay, so here are my disclaimers. And then here's the degree that allows me to teach this within the scope of practice. And also it is within my scope of practice to educate my patients on medications and to suggest medications to prescribers. You know, I'm still very careful when I suggest. So I don't tell patients you need this. I say it would be good for you to talk with your prescriber about maybe looking at, and then I might give names or I might give categories. When I am talking with prescribers, I will talk with them about, well, these are the symptoms I'm seeing, and so we know that that affects this part of the brain chemistry. And so if we could put something into their system that would help them metabolize faster their medication, and therefore they would have fewer side effects, and it wouldn't interfere with, you're going to learn this cytochrome P450 system in their liver. Why don't we switch them from Celexa to Lexapro? Now, Celexa and Lexapro are, Celexa was the first one. It has 2 components in it. We call them isomers. One is active, one is non-active. And it has to go through your system, and particularly a certain area, group of enzymes in your liver, to break it apart. And then the active one is carried to your brain and then it can finally work. There are all kinds of side effects, and we'll talk about that. But then the Lexapro is only the active isomer of Celexa. So you can take lower doses. It doesn't take as long to metabolize. It gets to the brain quicker, faster, and in the lower doses, it can really help in terms of a person's decrease in SSRI side effects. So I can talk with people about that. These are licenses that I've held. You know, I just figured be in school, see the world. So I have traveled to a number of places to present research and attend. You know, I attended my first international conference when I was at Fuller, and I went to Copenhagen. They had a hurricane. I got stuck. I mean, it was a beautiful experience. I'd do it again. And so I've been to Cape Town, South Africa. I've been to Rio and Brazil. And so I have just continued to go on. And there have been times when I moved, like for Idaho doesn't have reciprocity. So I had to keep my Idaho license until my Washington license until I got licensed in Idaho. I actually traveled for almost a year from Boise to Spokane every weekend to see my clients and keep my active license until I could get licensed in Idaho. And then Oregon was gracious. They had reciprocity with my Idaho license. And so I was able to use my Idaho license. When you're in the VA, you keep whatever license you are no matter where you go. And so I've had a number of our students who are doing early career in VAs, and they might be anywhere else, and often they choose Utah because it's the easiest to get licensed in right now. And so they'll be licensed in Utah and get that license going. And then as long as they're in the VA, it doesn't matter where they're licensed. The same with Department of Defense and Indian Health Services, because in those settings, you can be moved around a lot, and it takes a long time to change your licenses. Okay, now this next segment, I'm not going to show you everything. These are also on Foxtail, and some of them are irritating and some of them are downright disturbing. And I have one here where I hope you are in awe and go find out more about him. So just be prepared. I will tell you when we're going to look at the most disturbing one. And if you need to take a break during that, it's about children on meds, then I'm fine with that. So here's Dr. Bregan, and I think I have everything so you can hear it. There's no sound for me yet. Or yet.
I'm Dr.
Can
Peter
you hear
Bregan, and this is the first in my series of simple truths about psychiatry. Today I'm talking about biochemical imbalances. Has anyone ever told you that you had a biochemical imbalance? Did you go to the doctor feeling anxious or stressed or depressed and have them say, oh yeah, it's genetic, it's biochemical, you need a psychiatric drug? Well, you might be surprised to learn that the only biochemical imbalances in the brains of people who see psychiatrists are the ones put in there by the psychiatrists. We don't have any evidence that any routine psychiatric problem, from anxiety to depression and even schizophrenia, has anything to do with a biochemical imbalance. So where did an idea like that come from? We know the answer. It was actually made up by the brilliant minds at the drug company, Eli Lilly. Even before Prozac was approved for depression by the FDA, Lilly was sending its minions, its paid physicians and consultants, out into the world to say that depression was caused by a biochemical imbalance, and in particular, a kind of sluggish serotonin neurotransmitter, just not enough serotonin working. But Lilly knew from the beginning that it wasn't very simple, that this drug Prozac wasn't exactly going to jack up your serotonin like it was supposed to. The whole idea behind Prozac was that it would block the removal of serotonin from those active places in your brain called the synapses. You know, here's one cell and it's dropping Prozac into the, not Prozac, here's one cell and it's dropping.
Okay, I'll let you listen to the rest of that on your own time. He has a following. He has a lot of series. So let me, I was seeing some of your faces, which is why I laughed, but let me hear some of your reactions or some of your questions.
I'm just curious where he got his doctorate or his medical education from.
Yeah, I haven't looked that up, but
He reminds me, to be honest with you, and this might be kind of mean, but like, do you all remember the Hale-Bopp comet? Like, he looks, he reminds me of, gosh, what was that guy's name who had that cult?
I don't know his name, but I know who you're talking about.
Yes.
The ones that waited for the comet to come and take them.
Yes.
Yeah,
Yes, doesn't he look like that?
he does.
He's creepy.
I'm a little curious why he's a psychiatrist. Like that seems curious to me.
yes. And does he prescribe anything? Yeah.
Not what does he do when he meets with clients?
Yes. Yes. Now, I am not, you'll hear my biases, and I try to always tell you, this is my bias. And I am not going to tell you that the pharmaceutical companies are absolutely innocent. They aren't. One of the medications that is now, has been on the market for a long time is Seraphim. And Seraphim is blue Prozac turned pink. It's not chemically different. And what the chemical company did to market Seraphim was to create this thing called premenstrual dysphoria disorder. It is now in the DSM-5, and I'm so annoyed, I can hardly stand it. All you need to do, Seraphim is very expensive still, but all you need to do is take Prozac. A woman can take Prozac when she ovulates. You take it for 2 weeks, and it does help with PMS. But we now have a new disorder that it was very political. I watched it the whole time. And so I'm not saying that chemical companies are innocent of this, but I do think my bias is that we have enough evidence to this point to say that there are biochemical imbalances. The one that we have the most evidence is we can, from blood or urine, we can see byproducts of serotonin, and byproducts of serotonin in people who have completed suicide are significantly lower than people who have made who have ideation or people who are depressed. Now, we haven't gone very far, although we are working on understanding the biomarkers. Okay, I couldn't get this one to embed right, so this one I have to use the link up here. So this is Dr. Carl Hart. Okay, let me get it started and make sure.
This is Democracy
Can you
Now!,
hear it?
democracynow.org, The War and Peace Report. I'm Amy Goodman as we continue our conversation on the nationwide shift towards liberalizing drug laws. We're joined now by the groundbreaking neuropsychopharmacologist, Dr. Carl Hart. He's the first tenured African-American scientist at Columbia University, where he is an associate professor in the psychology and psychiatry departments. He's also a member of the National Advisory Council on Drug Abuse and a research scientist in the Division of Substance Abuse at the New York State Psychiatric Institute. However, long before he entered the hallowed halls of the Ivy League, Carl Hart gained firsthand knowledge about drug usage while growing up in one of Miami's toughest neighborhoods. He recently published his memoir called High Price, a neuroscientist's journey of self-discovery that challenges everything you know about drugs and society. In the book, he recalls his journey of self-discovery, how he escaped a life of crime and drugs and avoided becoming one of the crack addicts he now studies. Dr. Carl Hart, we welcome you to Democracy Now! The title of your book almost was the song we were just playing, Trouble Man?
That was my vote, Trouble Man, but the publishers thought that it wasn't 1973, so we should go with something more modern.
Both your research findings will surprise many and also your own path in life. Let's start by talking about, well, where you come from.
Well, I come from, as you said, I grew up in the hood. And so when we think about these communities that we care about, the communities that have been so-called devastated by drugs of abuse, I believed that narrative for a long time. In fact, I've been studying drugs for about 23 years. For about 20 of those years, I believed that drugs were the problems in the community. But when I started to look more carefully, started looking at the evidence more carefully, it became clear to me that drugs weren't the problem. The problem was poverty, drug policy, lack of jobs, a wide range of things, and drugs were just one sort of component that didn't contribute as much as we have said they have.
So talk about the findings of these studies. I mean, you've been publishing in the most elite scientific journals now for many years.
Yeah, so one of the things that shocked me when I first started to understand what was going on, when I discovered that 80 to 90% of the people who actually use drugs like crack cocaine, heroin, methamphetamine, marijuana, 80 to 90% of those people were not addicted. I thought, wait a second. I thought that once you use these drugs, everyone becomes addicted, and that's why we had these problems. That was one thing that I found out. Another thing that I found out is that if you provide alternatives to people, jobs, other sort of alternatives, they don't overindulge in drugs like this. I discovered this in the human laboratory as well as the animal laboratory. The same thing plays out in the animal literature.
What do you mean you're saying that crack is not as addictive as everyone says?
Well, when we think of crack, well, we have a beautiful example now that as the past year, the mayor of Toronto, Rob Ford, for example, the guy used crack cocaine and he did his job, despite what you think of him and his politics. But he came to work every day. He did his job. The same is true even of Marion Barry. He came to work every day, did his job. In fact, he did his job so well, so the people of D.C. thought that they voted for him even after he was convicted for using crack. But that's the majority of crack cocaine users, just like any other drug. Most of the people who use these drugs do so without a problem.
Compare it to alcohol.
When we think about alcohol, about 10% of the people, 10 to 15% of the people who use alcohol are addicted or meet criteria for alcoholism. Crack cocaine, about 15 to 20%. Same sort of thing when we look at the numbers. And we've known this in science for at least 60 years. We've known, at least 40 years. We've known this sort of thing. But we haven't told the public.
So you're saying someone who has wine every night for dinner would not be considered an alcoholic in the same way if you take crack every day?
Exactly. So the criteria to me, the way we judge whether someone is an addict is whether or not they have disruptions in their psychosocial function. Are they going to work? Are they handling their responsibilities? Or are they overindulging in the activity?
About your life's journey, how you ended up being the first African-American scientist to be tenured at Columbia University.
Well, that's a question that society should answer. I mean, when we think about the numbers of African Americans who are in neuroscience and why they're low and why the numbers are low, that's an issue that the society hasn't grappled with. And it's related to some of this marijuana talk that we're talking about. You played something about Kennedy earlier. Those kind of people, they sicken me, quite frankly, when we think about the role that racism has played in our drug enforcement, and those people don't acknowledge that. Those types of practices have played a role in why African Americans are not in many areas.
Okay, what are, let me see, I'm gonna have to do this because I don't know how to get back to, what are some of your responses?
I think a response that I have is I agree with some of the things that he says. And then I also, I'm like, there's some outliers that would kind of question what he says. And I'm just thinking particularly of Whitney Houston, who was on crack cocaine, and, you know, she had resources. And so I don't know. Like, I agree with the focus on like that there is poverty, and that a lot of the people that, you know, probably use drugs is to avoid because they don't have resources. But then I also think about affluent individuals who use drugs. And so, yeah, I felt like he provided some outliers. So I had a hard time with some of the stuff that he was saying.
Yeah, I think it's worth listening to the whole thing. It's just that I'm introducing you to this. You can get it on YouTube, or he has a lot of things that he looks at, and I bring it in just so that we can begin. I will do a section later on opiates and what are prescribed opiates or opioids, both of them, how they are affecting our patients, as well as how they interact. I also, because we are seeing this more and more, I will do later on a section on marijuana, because marijuana is coming into our offices. And we are in a place where we see particularly cannabinoids as being, or as being medicinal, not harmful. There's nothing that we take that's not harmful. So we need to pay attention. So crack cocaine can help people, but there are several things that we'll talk about in terms of when do things lose their helpfulness and become harmful. And that's one of the things we can bring to our patients in our offices. Other comments on Dr. Hart and what he's saying?
I think it's interesting as he talks about, you know, these drugs aren't addictive, or people aren't as addicted as we think they are. And I get it if criteria is clinical, you know, like DSM addiction, but the reality that let's take away the crack cocaine from this politician and let's see what happens, right? Like, I mean, yes, and the other thing is you start out with, you know, one glass of wine and pretty soon it's 2, 3, 4, 5, right? And it's a bottle. And so I'm kind of like, I don't know about that, right? Like maybe if we're talking like DSM, but in regards to addiction. And then I'm curious also about when we talk about medications that are highly addictive compared to medications that are not, you know, what would he do with that?
Right. And he does address some of that. And again, he has his own, he has presented, and you can find him all over YouTube. And so he does address some of that, although what he's really trying to do is decriminalize what we think of as recreational drugs. And so again, I'm just giving you a teaser of things and ways to think outside of maybe some of our boxes in ways. So I am right there with you, Cami.
I also think it's an important point of him talking to how few Black clinicians or practitioners in neuropsych and psychiatry, and also thinking of the inequity in how especially Black women are treated in healthcare systems and are perceived to tolerate pain more, and how that might show up in prescribing or a lack of prescribing for some psychotropic medication.
Yes, and I will, as we go through, I try to and will bring in some of the disparities. For instance, we medicate more Black people than we do white people. And when we are using medications, particularly with Black men, we tend to use our heaviest medications. And so inequities are done in a number of ways. One is access to appropriate medications. The other is over-medicating is an inequity because we have people in our stereotypic, what might be called assertiveness in a white male or bossiness in a white female is called aggression in people of color. And so how do we treat teenagers who are being aggressive? Well, we chemically straitjacket them, and we use medications that are prescription medications, higher doses, more difficult, more destructive drugs. And so, yes, we need to look at that, and we will. Thanks for that comment, Maria. Okay. All right, this is one that has some disturbing scenes in it. This is 2011, and I try to look for one that is more up to date. And as they are looking at more up to date, they're actually getting more disturbing, but also more specific. So I'm going to show us this one, and then you are invited to go and explore this in other ways. And this might be another one I couldn't get it embedded, so.
ABC News exclusive investigation and indictment of what the U.S. government does to some of the most vulnerable children in this country. We have spent a year investigating a horrible secret. Tens of thousands of foster care children, even infants, given powerful mind-altering that at times.
Can anyone see the video actually going?
Considered too risky, even.
I don't think we can see the.
Okay, thank you. Let me.
Diane Sawyer's face frozen.
I'm glad you could hear it though. No. Okay, do you see the picture? Okay.
For adults. And remember this statistic, foster children are given these potent drugs at an alarming 13 times the rate of other children. Tomorrow, a government GAO report will paint a portrait of a grotesque failure to protect foster children. But over the past years, so many of them have come forward to us to tell us about their lives, young kids living sometimes as sleepwalkers, sometimes reeling out of control.
These are the meds that I've been taking since I was 4. 1, 2, 3, 11, 12, 13.
Lexapro. The last one is Abilify. All their medications, they made me feel as if I had 1,000 bricks on my head.
They are tiny witnesses who came out of the shadows to tell and show us the mountain of potent drugs, antidepressants, antipsychotic drugs they were given in America's foster care system.
That was just a zombie.
And keep in mind, these are vulnerable children who've already been dealt a hand from hell, so many of them born into homes filled with neglect and abuse and bounced from foster home to foster home.
I were in 28 homes. I felt sad because no one would keep me or love me.
Consider the case of 7-year-old Brooke, taken from a drug-addicted mother, just 43 pounds, but given 5 mind-altering drugs at the same time, a combination that is deemed too risky even for adults.
Brooke, you need to get down. Come here, Brooke.
And foster parents who want to help soon learn that if they don't give medications, the child can be taken away.
We were told to put our faith in the system, and that's what we did. No one said the medications could be causing the problem. They kept saying she needs more medications.
But in Brooke's case, one doctor, a psychiatrist, recognized the problem. And Brooke went from this, being weaned off the strongest medications, to this.
No adult should be receiving the drugs that different variety, but certainly not at these ages.
Delaware Senator Tom Carper is holding a congressional hearing tomorrow demanding changes in the foster care system in this country. Parallel to the year-long ABC News investigation, the GAO report, which found in some cases psychotropic drugs were given to infants, even though there is no idea what the long-term effects of these drugs could be on a child's developing brain. And the report found in 5 states alone, out of 100,000 foster kids, 26,000 were on some form of psychotropic drugs. How is it happening?
When you don't have the time, the quick rush to judgment is the answer is a pill.
Michael Perino, prominent child advocate, says these children are issuing a cry for help. When we read that foster kids are medicated up to 13 times more than other kids, is it because they are a more troubled population?
They are troubled, yeah. There's no question that foster kids can be troubled, very troubled. Given what they've gone through, the answer isn't to always try to change their brain chemistry.
Medications that can keep a child from his life. Look at 11-year-old Chianti, prescribed 12 medications over the course of 4 years for conditions doctors now say he didn't have.
I'm not ADHD, I'm just naughty. I am not bipolar at all.
This is footage of Chianti trying to come off these medications. And this is Chianti today. He's in honors classes at school, and he got one prescription that heals beyond imagining. Chianti has been adopted.
Now you're part of the family.
Which takes us back to Brooke. Remember her? She too has a permanent hug, a mom, a dad, a home.
Yeah, you hug all the anger out, right? She just hugs and hugs and hugs and gets all the anger out.
So who is responsible? And by the way, your taxpayer dollars are paying for this. Medicaid pays for these drugs. Well, tomorrow I will question the Federal Drug Administration, and Sharon Alfonsi goes out to track down doctors.
Okay. Reactions?
I have a memory of in undergrad, I shadowed at a partial hospitalization program in a pretty, pretty rundown part of town. It was a very broken system. It gave me a glimpse into a very broken system. But I will always remember that the youngest classroom of children was preschool to first grade or something. And one of the things they had them do was in markers and crayons, write out all of their medications and color around it, and then tape to all sides of their desk so the workers could remember. But I don't know, just something about that was really, really disturbing, kind of seeing all the lists of medications that these children were on, written in their own handwriting. And I know that this happens, that children like that are over medicated.
Wow, that would be unsettling.
I'm really surprised at, and not from the video, but from, I don't know, I'm really surprised at what it's like for them, the detox of going off some of these medications. It's horrific. And I would imagine in a system where kids don't have one doctor that's helping them kind of navigate that they're coming off of and going on to constantly a variety of meds to try to squelch behavior, and like the withdrawal and it's just horrible. It's just horrible.
Yes.
I see this just as the easy way to try to squash some unwanted behaviors rather than getting at the root cause and you know, really addressing the children's needs, the tumultuous lives that they have. Of course, there's going to be some behaviors, and so this is just a way to get them to shut up, basically, and with dire consequences. It's gross.
Yeah. So when I was in Idaho, one of the events that we hosted to see if Idaho psychologists were interested in prescribing privileges, we brought up one of the prescribers from New Mexico to talk about his experience. And he'd been prescribing by that time for a number of years. And one of the things he told us is that as he has been prescribing, he has spent significantly more time taking children off of drugs that they've been put on and helping them do that safely than he has prescribing. So he went into some of the more rural areas as a prescriber, which was necessary. And he did therapy, he did parent training, but he took kids off of a lot of meds. And that's one of the things that I think is accurate for kids, people who are being for people who are getting the prescribing privileges is really taking people off of unnecessary meds. And part of it's not just with children, but it's across the lifespan. And when you work with elderly people, they are sometimes as vulnerable as some of our children because they are just put on one med after another. And people who are prescribing don't always pay attention to what else they're on, and people don't always know. This is just another one. It's a little bit more updated. You can look at this. Unfortunately, the message is the same. So I've gone through some of this. These are some of the qualifiers I need to give you. We're going to learn a lot. You will improve and broaden your scope of training, but after this course, you can't prescribe. It's an introductory course. There are still options once you have your PsyD that you can enter into the programs. So my degree is a postdoctoral Master of Science in Clinical Psychopharmacology, and everywhere except Illinois, it's still postdoctoral. Illinois has a unique program they're trying to work through, and I think it's at the Chicago School of Professional Psychology now. I've been to a couple of their presentations where it's a dual degree in clinical psychopharm, and a PsyD. But in order to be a prescriber in Illinois, you have to show that you have taken 5 science courses at the undergrad level. So most people who are in psychology, if they didn't do heavy science undergrad, have to go back to college and get these courses done. I need to tell you that when you are talking about meds, which you can when we're finished with this course, always defer to the prescriber. So if I am talking with a prescriber or a patient, or putting in recommendations, I always say, I think it would be good to talk with your prescriber about possibly changing your current medications. I think it would be good to have a conversation with your patient about whether or not it would be good to change from this family to this family, or could we lower this, or do we need an adjunctive to this. So I always refer back to the prescriber. In the same way, I get so irritated when insurance companies tell me what neuropsych test I can give to someone, and they're not a neuropsychologist. I don't want to be, as a person who is not a prescriber, telling somebody else what they should give to somebody. But you will be able to do education.
Yeah, that's
okay. Okay, questions at this point?
And they're able to put just the first name on that sheet, right?
Okay.
Yeah.
We have about 20 minutes left. I have in here, and it's also well done in your book, how did we get to the point where we have psychologists who are prescribers? And by the way, you may know that there are psychologists who also got their, sometimes their nurse practitioner degree. That's what I've seen the most. And so they work as a psychologist and they prescribe as a nurse practitioner. Nurse practitioners need to be connected with physicians. And so same as PAs. PAs are always doing the work under the license of a physician. We have currently, and I have this somewhere in the slides, we have 5 states that have prescribing privileges. The first one was New Mexico. The next one was Louisiana. Louisiana, the prescribing psychologist is still under the license of a psychiatrist, so they're linked there. And then Illinois, Idaho, Hawaii has done some interesting things with prescribing privileges. So I'm forgetting one. But obviously, as we have looked at medications, psychologists do so much work and get to know their patients so much better than the short visits to their PCP or their nurse practitioner or their chiropractor, that to be able to prescribe, we could also do more benefits. And so, but there is a debate, and I do have a video on that so you can see both sides. So Thorazine is the first psychotropic medication that was discovered. Here is the chemical configuration of Thorazine, and it was an accident. And what they found is that it helped to calm down particularly people with schizophrenia. And so when they, in the trials, and we'll talk about how do you get FDA approved in the different trials, you're hearing some of that if you've looked at how the COVID vaccine is going through trials. Our psychotropic meds do the same thing. So Thorazine, in one of its trials, it would have been the second trials, and in the past, people who were in long-term psychiatric facilities were guinea pigs for some of the new drugs. Same, also the military. And so then we would see what side effects. And healthy college students or graduate students have been paid to take these drugs to see what they do. And so when you open up a prescription in that little folded thing that comes with your prescription, and you look at the 7.2 font, they have to list all of the phase 2 and phase 3 side effects. And almost all of the psychotropics have death. And even if in phase 1, when they're doing the medication trials with animals, if there've been death by the medication, they have to put that on there. And so it's a little bit alarming. So I don't encourage my patients necessarily to look at all of those, because there are common and uncommon side effects, and we'll look at those as well. So this is just a minute long, so I'm going to, and I think this one is embedded, but it's not, nope. So let me let you look at this. It's 1 minute and 38 seconds long, and it shows you some of the disagreements in psychologists about whether or not psychologists should prescribe. And, you know, I absolutely respect that this isn't for everybody. And yet I also believe that we can be beneficial. So who did I forget? Oh, Iowa. I forgot Iowa. So you prescribing privileges in Iowa. And again, Hawaii isn't on the list because they don't have the full prescribing privileges, but they've got a little nuanced thing that they have done. So Dr. Puente, who is a neuropsychologist, who is a former president of APA, when he weighed in, which APA weighs in, to get prescribing privileges in a state costs a ton of money, and APA will give grants. And so he is just talking here about the need for people in the state of Idaho to have psychologists who know how to prescribe because of their suicide rate, which is among the highest in the country. If you were looking at the video, you saw that that Oregon is one of the states that is overprescribing to foster children. And if you've worked with foster children at all in the state of Oregon, or worked with foster parents, and I do because of my work with fetal alcohol syndrome, Oregon sends our foster children out of state, and Oregon has been cited, DHS has been cited for housing foster children in motels. So we have a lot of work to do in terms of how we work with children who are in places where they're not able to stay with their biological parents for a variety of reasons. Okay. So one of the things that is in your book, and I want to just highlight, why do we need a course like this? And I think you know these things, but how do psychologists who are trained to be prescribing psychologists, and this paradigm is throughout all the training that we have for psychologists. Now, if a psychologist is trained as a nurse practitioner, that is a different model. But one of the things that we do that is very different is that we move away from the prescribing model, and I'll show you some of the differences. The paradigm that prescribing psychologists use is to stay skeptical about medications. And this is one of my roles on the task force that I have brought. Not that our psychiatrists are not listening, but when this group of psychiatrists starts talking about a new, like we have to decide, so what diagnosis are we going to go to next? So we decided bipolar, and then we were looking at bipolar 1 and bipolar 2 and rapid cycling, and somebody said depression and somebody said anxiety, and they start talking meds. That is what they automatically do. And so one time, it took a lot of courage, because these people, they talk fast, they prescribe, they are psychiatrists, and they are from prestigious places, and I am a psychologist, and they don't know my training. And so I finally just spit it out one day, and I said, you're wrong. We need to think about, and if you look at the studies that for long-term health, people need to be in therapy, and medication, particularly for anxiety, is not the #1 thing. In fact, we need to have them in therapy. And I went on, it felt to me like I had just spewed for 20 minutes. I think it was more like 4. When I finished, and I started with, this is really hard for me because you're so intimidating, but I need you to hear me. And of course, my voice was a little bit tents, there was just this deathly silence. They didn't know what to say. They changed after that. A couple of them came up to me individually. I got a couple of individual emails, one from the director of OHA who said, good for you, this is what we, so I was a little bit, feeling a little bit better. And now when they see themselves go into meds, they'll say, but we need to understand that we need to look at such and such and such and such. And so sometimes we just need to speak up. So to stay skeptical, even though a lot of science is behind all of the medication, prescribing is not a science. And I'm going to introduce you to some tools that I use. I have Hippocrates on my cell phone. And Hippocrates, I was introduced by the pharmacist who taught one of our special courses in special populations and medications. And I have, Hippocrates isn't perfect, but I have found it to be so helpful. Because I'm not a prescriber, I just stay with the free part of it. I get CMEs on here, so you can look at articles that tell you some of the newest research coming out with medication, and I have found that to be really helpful. I go ahead and take some of the quizzes sometimes. I usually fail them, but it helps me to kind of just keep this all in my brain. I am a member of the American Society for Clinical Psychopharmacology, which are researchers, and usually I go to their March meetings. So most spring breaks, I went to Los Angeles and went to their meetings because that is the newest research in medication. And that's not all medications, that's just psychotropics. So I've done deep dives with that into some of the new, like Abilify and some of the newer medications, but also when you're prescribing to pregnant women, also some of the other medications and marijuana. We've had some very deep dives into the research on marijuana. We also need to understand that how we prescribe, the doses are absolutely poorly defined. And so when it gives you either on drugs.com or Hippocrates or a book, it gives you like Prozac, you start at 10 milligrams and you can go up to such and such. That's a guess. And so when we talk about the pharmacology, we're going to talk about why should some people start higher than other people? Why should some people start lower? Why should some people stay on this dose longer until they get the therapeutic? And it has to do with the idiosyncratic bodies that we have. Our own metabolism and our own liver functions are our own, and they're going to work our way. And every time we take a new medication, we need to wait and see what our body is going to do with it. It's not precise. So whenever a prescription is given, no prescriber knows if this is the right one for this person. And then, obviously it is complex, and we're going to look at that. So when you look at the drug lists that your prescribers are taking, your patients are taking, along with the list of all the healthy herbs and minerals they're taking, along with the foods that they're eating, along with their medications that they're taking for birth control, hypertension, high cholesterol, atrial fibrillation, whatever they might have. Now I want you to start thinking, how is their body doing this? What are they mixing up? And what medication is interfering with the metabolization of the other medication, or causing it to metabolize in much more active ways than others? So we're going to do that, and I'll show you the tools that you'll use. Hippocrates, you can go and look at the pharmacology, and the disturbing thing is sometimes it says pharmacology unknown to a medication that we're very familiar with, that we prescribe legally, and they don't know exactly how it works. The reason SSRIs, it's selective serotonin reuptake inhibitor. And when it first came on the market, the reason it was called selective is that we thought it was only going to go to serotonergic cells that synthesize serotonin. Well, we didn't know at that time all of the serotonergic synthesizers in the body. And second, it's not that specific. And so it really should be called SRI. They tried that for a while, but we already had SSRI in our brain. So anytime selective is there, that's what they wished it would be, but it hasn't been that yet. Okay, I talked with you about this. Okay, ethical principles. These are ones that we already know. These are ones that we have to pay attention to in terms of when we're talking about medication. What's the benefit versus the potential harm? There is no medication that we can give that doesn't have harm. And so we always have to think about that. And for your patients who are going to Walgreens and they're buying 5-HTP, that's serotonin. They're buying St. John's wort, that's serotonin. It has side effects, and it will have serotonin withdrawal and serotonin syndrome in the same way as if they were taking Prozac. Those are things we need to know. Valerian root has side effects. I love those things, and I'll do a whole lecture on all of the alternatives. And I have had patients who use those instead of using the prescribed for a variety of reasons. I'll talk to you about the fillers. I'll talk to you about why when the person went from the brand to the generic, it didn't seem to work, and why it's not just all in their head. It's actually in their gut, and they're right. The generic isn't working. Okay, we have 1 minute, and this is kind of the pace that I go. So when I've been in person, students have just raised their hand and interrupted me, and I would encourage you to do that. There is a lot that we need to go through, and we will spend time doing cases that I'll give you time to think about, but I also encourage you to ask questions. So I think you have just a few seconds. Any helpful things? Okay. All right. I hope I haven't discouraged you. I hope you're encouraged. I hope you're curious. And I know you're tired, and I will remember that. All right. Have a good rest of the day. Have a good weekend. We're going into a difficult week, and I want to keep that in mind as well. So be safe and stay healthy. All right.
Thank you, Dr. Andrews.
Okay.
Thank you.
Bye-bye.
Thank you. Is it just me saying hi to you? Just kidding.
Yeah, it's just you. How are you doing?
I'm hanging in there. I finally defend today, so.
Oh, yes, that's right.
Yeah.
That's right. How exciting.
So, hyperventilating, always good. No, and I'm just kidding. I did want to ask, so the DOD this is going to be DCT stuff. So one of the DCT people from DOD had explained to me that there's a pre-selection process that goes into this ranking. I don't know if you've heard about this before.
I know they have an extra step.
Yeah, and I just at least wanted to check with you because she had told me what it means, and I don't know what I just want to make sure there's no ethical issues going on. It's gonna get me in trouble.
No, okay. The military does that, and it is just a little more anxiety provoking for you.
Yeah.
In years gone by, I don't think you even know what happens.
No,
until the 15th.
Yeah, they basically said that everybody goes through the process, of course, the interview process and all those pieces, and then all the training directors have to get together, and they're going to be doing virtually, but they have to go with the selection board, because then the selection board has to then verify everybody who is actually eligible to be ranked, and then they rank separate. So right. I just couldn't remember if they tell you that you aren't eligible to be ranked or not.
Yes. If it is because of a medical, or if it's a medical reason, you are told.
Okay.
What I believe happens, the reason I think they're doing this is because the match, they have to be so careful with other processes that sometimes they have ended up being matched with somebody who then didn't get the full approval. So they're doing all the background checks, all the medical checks, all of that prior to ranking.
Okay.
And also I think part of this is, and this is just from hearing recruiters talk,
mm-hmm.
I think they were sometimes, I know they were irritated when, for instance, the Navy wanted this person and this person wanted to go to the Navy, but they ended up with the Marines. And so I think they've been, they're trying to make sure that they get the people who qualify to be full military, and that the people who qualify are getting ranked in the right place.
Okay, that makes sense. I just remember they had mentioned it, and it was something that she had said to me, and I know I was like, okay, so it's kind of like, why didn't the pre-selection go first? Because then you guys could have grabbed more people to interview, but then I understand that there's other historical systems that have been at play that have been there for so long, and they're archaic, and it doesn't help anybody. So thank you for clarifying. I just was curious. I mean, all that to say, I feel like the interviews went really well.
Good.
But just, I'm with Kristen. I'm tired, man. I didn't think it was going to be this exhausting.
Oh, yeah. Yeah. And see, I think one of the things that could have thrown students in this cohort is you knew you didn't have to travel.
Yeah.
And you thought, well, no big deal, I'm at home. But these 4 to 6 hour on Zoom all day things.
On average, I've been doing, so the military did 2 days. Each of them did 2 days, and they were a minimum of 7 hours. And I think the latest start I had was at least 5:30 my time. Everyone else I had to be on by 4:30, so I was up at 3:30.
Yeah.
I was like, do you guys not know that you have like applicants on the West Coast?
This is just part of the process.
Yes.
They figure if you can't do this, you can't do roll call.
Yeah, basically. So yeah, and I just wanted to say thank you, because many of them had quoted your letter for me, and so thank you very much for that. And so I'm just excited for the process.
Yeah, good. Are you done?
I'm done. As of yesterday, I had my 4th interview, which was with the Southern Nevada VA, and had the military not been a thing, they're a fantastic site. They were really, I mean, out of their structure and what they provided for people there, they were the only ones they've seen from a VA that let you have a 12-month rotation if you wanted to stay there. So you didn't have to do this weird choppy thing.
Yeah.
And they let you be in the PTSD clinic, they let you be in the substance clinic, they let you be in all of these different things, and if you wanted more, they completely were fine with that. And I was like, oh, well, you guys would have been fun, but all things aside, so.
Yeah. So are you ready to rank?
Yeah, I'm pretty sure. And I did read it, because I remember you and I had a conversation that if I had gotten interviews from VAs, we need to have a conversation about whether they got ranked or not. And then I read through one of the brochures, and then my contract that got sent to me because of being a health professional scholarship recipient, and they distinctly said in a paragraph,
you must rank these separately. Like you have to only rank military. If you're interviewing for military because you've been cleared for military, you can only rank them because they don't want the issue of me getting matched with a VA when I get them. So I did do that in the contract, and I did get clarification from my mentor that she said that's the process.
Yeah.
So it'll probably end up being San Antonio and then Malcolm Grow, which is Maryland, and then Wright Pat, and its location played a huge role. And I was kind of shocked by Wilford Hall because they're the largest, but they're the only ones that have the best supervision, the highest supervisee to intern ratio. And so I was like, okay, well, you guys stole that seat, so I'll give it to you. So that I'm ready to rank.
Okay. Yes. And the reason that, the reason that you did, and you were encouraged to go through the process with other VAs is because I do know not all people who are looking at military were allowed to go forward, and so now they have other ones.
And had I not gone through, because we had a conversation with Lauren, because I was like, I feel bad because I wasn't the one that had to apply to like 15 or 16 places. And then I had to kind of check myself and realize actually my interview process started 2 years ago.
Yeah, exactly.
So I am one of those people I've passed MEPS. I've gotten everything cleared. I've been sworn in. So they referred to me that even though I was an applicant, they kept referring to me as Lieutenant Hager. They wouldn't refer to me as anything else. So that was part of why I was like, okay, I'm comfortable to not rank anything because I do know that you've already signed me on. You know that these pieces have been met. So I don't foresee why I wouldn't be selected for the process because I was able to get my military ID card last week. So I don't know if you would and again, I think at this point, it's just where I might end up. I'm not saying that to be arrogant or cocky, but I think that we ran into that issue where there was a handful of people in those interviews where I had recognized that they were also HPSP, but I got really confused as to why there were so few because I remember there being 15 or more. And apparently at some point at the end of last year, over 75% of HPSP people went back and reneged on their contracts and said, I don't care, I'll pay everything back. I don't want to have this commitment to you. So they ended up losing quite a few health professional scholarship individuals.
Wow.
It was pretty apparent they were scrambling a little bit in some of their interviews. So
yeah, wow,
it's weird, and I can't blame them, to be honest. There is a lot of pieces they did pull us aside and said, I know that we put in your brochure that it's a potential deployment and we've now switched it to a probable deployment. How does it feel? It's like, I don't know. I don't know. I have to tell you that you're going to tell me where to go. And I did have a postdoc question. So I know Oregon says something about a postdoc, but is it more that you need to have 1,500 hours or you need to be in an official postdoc position?
Oregon still allows for residencies, and those are 1,500 hours supervised before you are licensed.
Okay, and that's required to have a residency supervised?
Yes. So the military will work that out for you.
Well, because I got confused because they had put it up on a couple of their slides where, oh, just so you know, we have postdocs.
Yes.
And I'm sitting there, but I'm like, how does that work? When I finish my residency, you put me in my first assignment, which is a minimum of 3 years. And I'm typically by myself at that point. I'm running a clinic or I'm doing something separate. And so I was like, so how does a postdoc work? So am I applying for that during my residency year? And then basically you get rid of my first assignment because I took a postdoc. But I've also heard people do the 3-year requirement. And if they don't want to make a career out of it, they get out and then do their residency after they're out.
Oh, yeah. When I have looked at our military students, and I look at their end of internship, I think all of ours have gone to an assignment where they got supervised.
Oh, and that can
So
count.
that's, yeah.
Okay.
And so that, yeah, even the one when I first got here, she was the one who was going into the Air Force, had the scholarship, but didn't get into the Air Force. And so she went to round 2, phase 2, and got into a VA, and she was scared she was going to have to pay everything back, but it wasn't for lack of trying. And so she went to the Alaska VA, and when she got, for her internship, when she got done with that, she went right into active duty in the Air Force, into a supervisory.
Yeah, so they've had a couple conversations about it. They haven't really had a lot of conversations, I know, with the people like myself. I just actually, as of tomorrow at 12 a.m. our time, I switch active. They already gave me my orders, so I'm active starting from January to March, and then it goes from March into April, and then it'll switch again when I have to go off to basic training. But that was the one thing I was confused about, because I was like, okay, you guys are talking about a postdoc. I love a postdoc, but then they don't tell you until you get the postdoc, but then you've now just incurred 6 years that you now owe them back. So you have
No,
so as
no,
long as you get
they will work it
supervised
out for you.
Okay.
Yeah.
It's supervised hours that then they sign off, so then you can take your EAAA.
Yes, yes,
Okay.
yes,
Yeah,
yes.
makes more sense.
And I'm trying to think, so the Army is always slow. Are you Air Force?
I'm Air Force. They're much
Okay.
faster.
Air Force and the Navy are typically right on time.
Yeah, and they've made that very clear to me. Made that very clear to me. And I ran into a couple people, because I've had a couple people in the interviews that have either interviewed outside of the branch, and then there's people who, like, we've gone to the Center for Deployment Psychology, we've done a bunch of classes together, and so I recognize them, and I've asked them, what's been your experience? Because we had one guy that was jumping between Navy and here, and there's so much stink that they throw towards Air Force because they're frontlining in a lot of the military psychology and providing disaster mental health and all that kind of stuff. But they are on top of it because they know until I pass my EPPP, they can't deploy me. I don't then start ticking off my service requirement because I owe them 3 years, and it doesn't count until I get licensed. So it's in their benefit to get me licensed as quickly as possible and to get me off into my assignment as quickly as possible, so then they can deploy me if and when they need me.
Yeah, so they will probably, so you have EPPP Part 1. No, Oregon hasn't required Part 2 yet. I don't think so. But so you can take EPPP Part 1 once you get your degree.
Okay. Just
so you're
apply and get it.
Yeah, yeah. Just, you want to take that as soon as you can. And so do you know when your internship will start?
So if it's the difficulty that they're having because of COVID is that I have to go through OTS, and they're still deciding whether or not we're doing the 5 weeks or we're doing the 8 weeks. They have no idea, and they just need to know if I have enough field experience and to get me into the site. So if it's Wilford Hall, I read on their brochure that I start the middle of June, but that's when OTS starts. So historically, when I've talked to Trisha and I've talked to Annie, most people are starting in August. And
Trisha was August.
So basically, and she was at Wilford Hall. And
okay. Yes, that's right. She was.
So they basically say they're either going to send me the beginning of June into middle of July, or they're going to send me the last week in June to the end of July, and then I get my orders, which basically says I have to report to whatever base within 48 hours. So I was like, okay, husband, I'm moving you well before I'm going off to training. And so they say that's when it starts, would be August. And then I get my next assignment. I make my selection in February, and then I get notified in March where I go.
Okay. So then you will get your degree posted early August.
Okay, that's what I'm going to need to know.
So what happens is that to get your degree posted, and then you can register for the EPPP for Oregon. Your training director will have to send your final evaluation and a letter that says you've completed. Sometimes that's a certificate, but we have to have both of those. And then Dr. Jones will sign off as your DCT. Then it goes to Leisha. Leisha actually checks everything that's done and posts your degree. And when you get the email from Leisha, then you have your degree, and now you can go into a postdoc and you can sign up for the EPPP.
Perfect, because that's what they have, the elective course, like they have the elective rotations, and that was the one thing I found was interesting for military is they have them, and then if I want to push for a certain elective rotation, they'll help me get a certain elective rotation.
Okay.
But that was one of them is the EPPP elective rotation to basically give you a block of time to like study for it. And so I said,
Do it.
"Great, I'll do it," because they basically already, like, I hope that the students that are behind us know that the level of competitiveness now my application has, because I have a date for my dissertation final and they know it's now going to be completed, is ridiculous, because now they don't have to pay for me. I don't have to lose an elective rotation. Like, they were so excited to hear that it was getting defended this week, even though I'm terrified. But it's one of those pieces that I was very shocked at how competitive that really makes you. So I hope that following students are aware of that.
Yeah, I don't know. I couldn't persuade some students, although I preached that all along, but
It's one thing, I mean, it's one thing to hear it from, you know, your DCT, but it's I think for me what solidified it, as I listened, I was like, sure, let's get it done. I just don't want to deal with it. And then actually hearing like, oh, look how amazing it's going to be for you. And now you get to have all these extra fun things. And it's what I got from it was, we're going to now reward you for getting this done. So it's more beneficial for you to get it done. It's like, okay,
yeah.
well, that makes.
Well, just tell your RVT people that.
I said it. I mean, I said it this week. I said, guys, get it done. Just get it done.
Yeah.
Don't take it to district. Don't take it to internship. It's going to kill you, and you're not going to be able to focus on your clinical work. And I don't see how it doesn't then end up impacting your clinical hours. Like, I don't see how people can't see the cause and effect there.
I think it is just that the dissertation, particularly in a PsyD program, is something that the majority of students just want it to go away, but they procrastinate.
Yeah.
And
yeah. Well, and I got pushed on one guy, and now I see the time, but I got pushed on one interview because he asked me, so, you know, looking at your CV, it looks like your research is your weakest point. And I know who he was. I don't know if you're familiar with Dr. Talcott. He does all of like the smoking cessation and like, I mean, this guy has been published 40 times. It's very apparent I know what position he holds. And so how do you think, because your research is poor and you don't come from a research, you know, program and blah, blah, blah. So, well, okay, I have 3 research things and I have another one. And what I lack in number, I gain in passion. It's passion projects. So then I dazzled him with my research stuff. And I was like, you tell me that I don't know my research. Okay. I can tell you exactly all these things, even though I'm coming from a clinical degree. And he was like, oh, interesting. It's like, yep. Shut down. Don't tell me I don't know my research.
yeah, well, and you were on the RVT of our most prolific researcher. So
they did read that in your essay and they thought that was funny. And he even made a comment. He was like, he got halfway through my interview and then he stops and he's like, well, you don't have any shortage of energy. And I was like, yeah, I was told that there might have been some mention in my letters about that. And he goes, yeah, I read it in all the letters, but I didn't really believe it. And I guess now this is like believing it. I was like, okay, well, fine. I was up at 4 this morning, so I'm just dazzling you with the fact that I'm awake. So take it. Awesome. Well, thank you so much, Dr.
Yeah.
And I consider it a great honor that we get to have you for a class, and you will be dearly missed, but I'm glad that we get to steal you.
Thank you. Thank you.
Awesome. All right, then I'll see you next week.
Okay, sounds good. Bye-bye.